Thank you for attending today's webinar. I am General Grant, Vice President of Strategic Initiatives at Aventura. Aventura is a Denver-based software company that was born in a hospital. We deliver context-enhanced clinical computing solutions that provide clinicians the applications and information they need when and where they need it. It is my privilege to introduce today's speaker, former HIMSS chair and a member of Aventura's Healthcare Advisory Board, Dr. Barry Chaikin. Dr. Chaikin is a physician with over 20 years' experience in medical research, patient safety, and informatics. Dr. Chaikin is a board certified in general preventative medicine, public health, as well as healthcare quality management. Today, Dr. Chaikin is discussing the driving factors of healthcare spending and how to leverage the functionality of software applications to build effective and efficient clinical workflows. I will now turn it over to Dr. Chaikin.
Thank you, General, and good afternoon, and to some of you, good morning, everyone. I appreciate you taking your hour out of your day to listen to this webinar. I hope you will find it to be interesting and helpful to you in your work, and we will have a period of time for questions at the end. So I'll go through some of these slides for you, and hopefully it will be valuable to you. Some of the things I'm going to cover in the next 40 minutes or so before questions are some of the driving factors in healthcare, what our current state looks like, ideas around smart workflow, and then talk about applying functionality to address clinical workflows. I think some of you are familiar with this statement. It's been floating around for probably almost 5 years now. A crisis is a terrible thing to waste. And what that really means is when a situation exists where there are huge problems, it's an opportunity to make the necessary changes to make the overall situation better. This quote was from Paul Romer. He's a famous economist at Stanford University and has done a lot of work in the area of economics, not necessarily healthcare economics, but economics in terms of managing our global economy. Well, I think all of you are familiar with some of the details in this slide. Our spending as a percentage of gross domestic product exceeds 18%. In yesterday's State of the Union address, you probably heard the President talk about healthcare spending and the need to be able to control healthcare spending, particularly around the spending on Medicare and then secondarily on Medicaid. Even on the response from the Republicans, they talk the same about the issues about how need to address healthcare spending. When I went to medical school a while ago, healthcare spending really wasn't that big an issue, although the inflation in healthcare was significant. But now it's really become a real crisis where almost 20% of everything that is produced in the United States is around healthcare. We can recognize that that's truly unsustainable, and we need to really do something about it. At the same time, you might say, well, we spend a lot of money on healthcare, we probably get a lot of value for it. Well, the details are not so great in that area. Let's look at this slide for a moment. And this slide, when I first saw it, really upset me because what it's talking about here is the ability for us to provide healthcare to a population to prevent death. I'm not saying prevent death that's inevitable. I'm talking about preventable death. And the reality is the United States does worse than everybody else in preventing death in people that it actually could be prevented in. And as you see, there's been significant decreases or improvements in care across the board, whether we're talking about France and Australia, Italy, Japan, but the United States really trails everyone else. And additionally, the amount that we decrease compared to everybody else is significantly less over that 10-year period, 1997-98 to 2006-2007. So the question is, we must be doing something wrong. We are spending a huge amount of money, yet we're not getting the value we really need to get from it. Let's look at the next slide. What we're looking at here is back in 2005, there was a report published. It was done by people at RAND. It was published in Health Affairs. And it was talking about, let's assume that we apply information technology to the healthcare industry. If we go ahead and do that, what will the impact be on healthcare spending based upon what we expected to be productivity improvements from using health IT? So let's look at the red line for a minute. The red line is That's projected healthcare spending from that 2005 study, what it exactly is in 2000, 2004, and then projected all the way out to 2016. The yellow line is what our actual healthcare spending is. Okay, so as you can see, it's somewhat close to what the projection was based in 2005 by Hillestad and others. Now, they went ahead and compared it to two industries. Let's take the retail industry. Retail industry using information technology had a 1.5% annual productivity improvement. So that's the blue line. So if healthcare could expect a 1.5% annual productivity improvement, like you saw in retail, you would have healthcare spending of the blue line. If we were as effective in using information technology as the telecom industry, then we'd have a 4% annual productivity improvement, and we would see the green line. As you can imagine, the green line and the blue line are still below the yellow line, which is what we're currently seeing, and the red line, which is what the projection. So the question is, are we really getting value from health information technology? And if we're not getting value, why are we spending all this money? Before I go further in this presentation, I want to suggest to you, I am convinced that information technology is going to have a huge impact on healthcare. It's going to have an impact on healthcare both in quality and safety, and it's going to have a great impact in spending. The issue really is we need to figure out how to apply the information technology effectively, and we have to be patient in how we do that because we are just learning. Unlike banking and retail and telecom and a variety of other vertical industries, healthcare is very, very complicated, as all of you know, and it's not as simply as automating bill payments or automating financial transfers or automating ordering things online. It's much more complicated than that, and we're still learning that, and I'm very confident we're going to make some changes in that. But let me take you through a couple more slides to continue to set the stage of why I think we're going to be able to make a difference. What's our current state in using IT? I think all of you are familiar with HIMSS, and you're probably familiar with HIMSS Analytics. This is the latest information from HIMSS Analytics about the use of EMRs in hospitals. As you can see, only 1.8% of hospitals in the third quarter of 2012 were at stage 7, which is essentially a completely digital hospital, essentially paperless. And at the same time, over 7% of hospitals has absolutely no EMRs and real health IT capabilities. And most people are at stage 3. So we've been working at this and working at this. I'm familiar with some of the data from several years ago. We've made a great improvement. We're above 1% for stage 7. We're above 40% for stage 3. That's really great. We still have a long way to go. Clearly, the High-Tech Act had a huge impact in moving these numbers along. I think we're still learning. We're learning how to use CPOE and clinical decision support. We're learning how to use closed-loop medication administration. We're learning how to be in a paperless digital hospital. And I think we're learning very good things that are going to be applied and show great results in the next years ahead. How are we doing in the ambulatory care space? Well, this is starting to get rolling. Clearly, high-tech was funding a lot of this, so it's not surprising that you see more than 50% of reporting practices still being paper-based. That, I believe, is going to dramatically change, not only because of high-tech, but because today over 60% of physicians are employees. So that whole concept of that single doctor or 2 or 3 doctors in a small group as a standalone business is really disappearing, except possibly for rural areas. So therefore, there's much more consolidation of medical practices in the ambulatory care setting, which allows the economy of scales to really accrue there, where you'll get to see more and more use of health information technology. Let's talk a little bit about EMR adoption. About 54% of physicians use EMRs. You can see, not unexpectedly, that people under the age of 50 as docs use them more than people over the age of 50. The larger the practice, more likely there's going to be EMR adoption. The fact that they're owned by a larger organization, whether it's an HMO, a community health center, or an academic health center, you're going to see more of that. And then clearly, those who are just single physician owned are going to be less likely to have those practices. I expect all of this to continue to grow and to change. More and more physicians will be using that. And as the solo practitioner goes away, more and more physicians, primary care physicians, will be using EMRs. So I want to bring up one interesting thing in EMRs, which is it's very difficult for EMRs to serve the needs of various specialty practices because they're so uniquely different. So I suspect there'll be a somewhat of a lag in the adoption of EMRs in those specialty practices. But in basic primary care, internal medicine, OBGYN, those pediatrics, I think you'll see rapid growth, while the others may lag a little bit. I wanted to talk to you a moment about processes. And this is a very simple explanation of processes and how processes impact the probability of success. What I'm talking about here is, let's assume a process that requires 7 steps. Let's think simplistically. We're going to do give a medication to a patient. So the physician has to prescribe it. It has to get, that order has to be transcribed, sent down to the pharmacy. The pharmacy has to fill it, give it to a transport person, get it up to the floor. Here I'm assuming no medication administration system, obviously. And then the nurse has to get the right medication and then give it to the patient, at the right patient at the right time, in the right dose, etc. A lot of different steps. Well, all of you remember when you were in high school or college and you got a 90 on your exam, you thought you were pretty smart, that got you an A, everything was great. Well, the reality is, if you have a 7-step process and each step has a 90% chance of being a successful step, meaning you're doing it right, after 7 steps, more than 50% of those activities you did will end up in a bad result and end up in a failed process. So if at each step, 90% of chance that you'll be successful at that step, after 7 steps, your overall process, what you're trying to accomplish, will fail 50% of the time. Well, let's see what happens if we increase the probability of us being successful at every single step. What we find is that we got to get close to the IT standard of 5 nines to have an acceptable failure rate of less than 1%. Now, think about that. Think about how complicated healthcare actually is. How many steps are involved in the delivery of various healthcare? I think every single day it's a miracle, an absolute miracle, that more medical errors don't occur in hospitals. How complicated, how many steps, and the probability of you having to do each of those steps absolutely correctly. That's absolutely amazing. So the risk of making a mistake is increased by the complexity. So our goal is going to be, we want to be able to reduce the complexity of the processes we do, while at the same time ensuring that each step of those processes has a higher and higher percentage of us doing it absolutely correctly. Well, what's happening because of the Affordable Care Act, or sometimes people call it Obamacare? There's coverage for pre-existing conditions. I'll go through some of these and I'll explain why altogether they mean something very important, at least in this area, in the area of processes and efficiency and effectiveness. There are no lifetime caps on new coverage. Preventive care is universal. Policyholders can't be dropped for pre-existing conditions, which essentially prevents insurance companies and providers from going along and saying, hey, we'll insure all the 20 to 35-year-olds because we know, and by the way, we'll choose the 20 to 35-year-old males who, by the way, never go to see the doctor, have a low probability of getting ill, are not high utilizers, and we'll ignore the 50 to 65-year-olds who we know are going to most likely have a higher percentage of chronic diseases and are going to be higher utilizers. So it eliminates the ability to cherry picking. And the incentives completely change for both the payers as well as the providers. What we're talking about here is before we were focused, before the Affordable Care Act, and of course it's not going to come into complete effect until 2014, the whole focus before was doing more. More was thought to be better. More was a way to generate revenue. More was a way to get profits. The focus was on fixing things and doing more. By changing the incentives, which is done through the Affordable Care Act, the incentives are no longer on doing more. The incentives are more on keeping people well. And that's why you're seeing the growth of accountable care organizations. That's why you're seeing the growth in prospective payment. That's why the focus now is in taking a population, risk adjusting it, getting a global capitation payment for that population and working to keep them well. That changes everything that we do and how we focus on healthcare. And it makes it much more important that we go ahead and figure out what are the best clinical processes we need to deliver efficiently and effectively to deliver that healthcare. Because if you aren't able to do that, you fail to do that, there is no way you can be able to survive. Because you're getting prospectively being paid. You're being punished for medical errors. You're being punished through lower reimbursements or clawbacks through readmission. So therefore, your incentive to do things as well as possible, and you're going to be measured upon them. Let's think of some other trends that are changing. So as I said earlier today, the majority of physicians are employees. The number of private practices are shrinking. The number of physicians who are growing up with health information technology or just technology in general is growing at an incredibly rapid rate. Those who are not used to information technology are retiring. And academic medical centers are buying practices up to act as a feeder to bring people into their organization. The majority of medical students today are female, and you might wonder why. The reason for that is that medicine is one of the few, if only, professions where a woman takes time off or work part-time to take care of a family and at the same time not lose her status in terms of her profession. There's a greater interest in quality of life, and also medical education costs, which some of you may know is very, very high, is driving people to a variety of specialty careers while they may be interested in primary care. And that, of course, is limiting primary care providers. And medical school today highly integrates information technology into the education as well as into the postgraduate training that will occur in a variety of residencies. As you can imagine, academic medical centers are embracing information technology, and therefore the physicians are, newly minted physicians are choosing to go into their practices that include that. Interestingly enough, it's for several years I've heard the same story about graduating medical students who are trying to choose residency programs. And one of the factors that they choose in a residency program is, what is the status of the health information technology in that particular organization? You know, before we did all of these changes, physicians were incented to provide more care. That was based upon the reimbursement model. And I'm not saying to you today that physicians were there to turn the crank, see more because they just wanted to make money. I think that all of this was subconscious influence, essentially establishing a moral hazard. For those of you in academic medical centers or know people who work in them, you might realize that for many of them, they no longer allow pharmaceutical representatives or medical device representatives to come on their campus and offer the physicians, the residents, or anyone anything of substance. And when I say anything of substance, I mean physicians and residents can't accept a pen, let alone a dinner. And the reason for that is we know from psychological studies that when you offer somebody something, they are then and they accept it. They are predisposed to help you. So there's this moral hazard that's established by giving people something. Well, in the case of a reimbursement model, the subconscious incentive is, well, I know if I go ahead and do this study, I will get reimbursed for it. Well, that is going to change when we change our reimbursement system. Facilities are incented to do more. In some instances, if a patient was discharged and readmitted relatively soon afterwards, the DRG would kick in again and they'd get paid more money. So the incentives were not in the right place. And lastly, and I don't hear a lot of people talking about this, but I think it's really important, patients are incented to obtain more care. And how are they incented to obtain more care? Well, they're removed from the cost. They don't pay anything. And the advertising, they see Lunesta advertising. They see the Cialis advertising. They see a variety of other advertising that gets them to say, well, I have a viral illness. I got to go to the doctor. I got to get a medication for it. I got a stuffy nose. I got a runny nose. I have a little difficulty sleeping. I don't feel good some days. I need to go to the doctor and get some medication for that. It fuels that demand. And I've heard many colleagues who've said to me, you know, I try really hard to not give out antibiotics that are unnecessary, give out a variety of pharmaceuticals that are unnecessary. But I have the patient come in and said, I saw the ad, I read about it, I really want it. If you don't give it to me, doctor, I'll go somewhere else and they'll give it to me. That's a big problem. Patients think more is better. Some of them think that if I get 2 chest CTs, well, in the same day, that's better than getting 1 chest CT in the same day. And the reality is that all is not true. So we need to change the incentives for the physicians. We need to change the incentives for the facilities. We're doing all of those things now, and we're working on changing the incentives for the patients so that they know actually what the quality of care they're receiving and what the costs are associated with that. I'm proud to say here in Boston, one of the large hospital groups is putting together a program where their patients will be able to go online and look up quality metrics and cost metrics from the variety of institutions in the area to choose where they want to have, say, their hip replacement or knee replacement or their elective surgery. That's quite innovative, and I think it's going to be quite impactful going forward. You know, the accountable care organizations are really a capitation experiment revisited. We had that before with independent practice associations where insurers would capitate or pay a capitation fee to an independent practice association which then would be responsible for taking care of a population of patients. As many of you, if not all of you, know, that whole experiment very much failed. One of the problems with it was the organization, the IPA, was capitated, but the individual physicians working under the IPA were not capitated. So therefore, the same incentives of turning the crank, of seeing more patients, focusing on fixing things instead of preventing problems, still existed, and therefore was one of the problems why that capitation experiment really didn't work. I think in an accountable care organization, we have a better chance of all of this working. Why? Because the focus is on global capture of all the care that would be provided to the patient, inpatient and outpatient, and eventually into a nursing home, pharmaceuticals, what have you, all under one umbrella, a global population paid on a global way. There's global payments that are going to be risk adjusted. The organization will be financially at risk, so those who are able to manage their patients well, keep them healthy, keep them out of the hospital, do things that are effective and efficient rather than things that are unnecessary will be able to reap those rewards, and those who are unable to do things well will not. The problem is, or the challenge I should say, it's not a problem, it's a challenge. The challenge is can clinical care be transformed from the episodic care to managing a population of delivering high quality while incenting lower costs? I think with the right metrics, I think with the right approach, we can actually go ahead and do that. Let's talk a little bit about smart workflow, which I think is a good solution to us being successful there. You know, IT has fallen short for a variety of reasons. Oftentimes, health IT has been implemented in a way that mimics the way we've been doing things before, such as a paper record. And that's also led to the fact there's sluggish adoption, meaning it's not focused on improving the care, it's just focused on working. And I think it takes a lot of effort to make health IT work, but I think we have the tools and I think we have the basic knowledge to be able to be successful there. Clearly, anytime you have change in an organization, there's going to be resistance to it. And health IT, particularly EMRs, have a steep learning curve. They're very complex. It requires us to do a bit of change management by changing the processes. And then we have to work to interconnect all of the different health IT to make sure they work seamlessly. So again, the focus is not on implementing the application. The focus must be on putting together processes and an entire system that works towards delivering a clinical care that then delivers a particular clinical and financial outcome. We have to focus on the system as a whole versus the individual application. And only by doing that will we be able to overcome some of the problems in implementing health IT and some of the reasons for its falling short in terms of what we expect from us. We have some changes on our way. There's working towards robust interoperability for the federal government, setting some standards through NHIN and DirectWay. There's the whole concept of pushing towards patient-centeredness with the Federal Blue Button Initiative, which is a way for all of us to be able to soon download our personal health data into an easily readable format, such as an Excel spreadsheet, so that we can have our data and transport it from one place to another. And we need to be able to develop improved user interfaces through EMRs so that they're easier to use for physicians and they flow according to what the clinical workflow the doctor would actually want to use. They have to be able to be utilized, be implemented, as I spoke earlier, to facilitate the work of the physicians. And then we have to understand what are the best practices of using the various information technology tools. I think, again, today, a lot of what we've done is we've implemented these tools by just installing them and having them mimic a paper record. What we need to do is understand their functionality, understand the complexities and capabilities of these variety of tools, and weave them, tie them together to achieve a particular outcome that we're looking for. Well, one of the things people ask me a lot of the time is they say, well, how do you go ahead and drive this adoption? How do you get people to accept the use of this technology? First thing I want to tell you is we always need somebody who is a leader, a driver, who can show people the value of using the technology. But that person is not an innovator. It's what we call an early adopter. Before I continue, I just want to say one thing. Every time any of us is challenged with doing something new, we will fall into one of these categories, number one. And number two is we won't fall into the same category all the time. There are some things that we will want to innovate on and other things we will be laggards about. So don't think that it's better to be an innovator than a laggard or early adopter than a late majority. The reality is we all fall into one of these 5 categories based upon what we're asked to do. Of course, if we have an interest in information technology, we're probably not going to fall into the laggard stage very often, but there will be times we'll say, no, you might say, no, I don't want to use the information technology because the way I do it this way actually works better. So who do you go after? You go after the early adopters to get people to be leaders in adoption. The reason for that is those are the people who say, okay, let me understand what the benefits are of adopting this new thing, this new technology. But I'm going to spend some time to understand the costs associated. And I'm not saying necessarily the dollar costs. What I'm talking about in cost is the time that I'm going to have to put into it, the changes I'm going to need to make. If this new technology truly delivers on what I think it can do, its benefits, do those benefits exceed the costs that I've been able to associate with it? And if I think there's a good probability benefits exceed costs, they try it. They adopt it. They're the ones who will drive adoption. Early majority will wait to see for more evidence of benefits. So the same will happen with late majority. The laggards will need to be pulled along. The innovators, on the other hand, will try new technology irrespective of measuring the potential the costs associated. They see new technology, they think there are benefits, they'll go ahead and adopt it just because it's there, and they'll adopt it because they get excited and jazzed up by the new technology. So the people you need to go after is early adopters. Well, let's assume you want to go implement some new technology in your organization. How do you go ahead and do that? Well, one of the things I suggest to you today is focus in on things that are easy first and hard later. Let me give you an example of that. The green is the risk or the cost. Remember, not dollar cost, but cost of political capital, influencing people, asking for favors, that type of cost. And the orange is the total benefit. Clearly, if we're talking about a clinical solution A using technology, the costs are low and the benefits are high. What would be that? Well, maybe you're creating a physician portal that doesn't require the physician to log on, but it's available to them. If they use it, great, you can get some significant benefits. If they don't use it, it does not disrupt your workflow. Well, let's assume we go ahead and we achieve a measly 10% adoption in that A, in that relatively simple IT. Well, the problem with that is if we achieve low adoption, it may just be above the benefits exceed the cost of the risk. But clearly, as you have increased complexity of the various solutions, surely you're not going to be successful. In order to be successful in using IT, you have to have high levels of adoption. Well, what happens if I can increase the adoption for that first thing that I do, say that physician portal, to close to 100%? And then I get everyone involved. I get the early adopters involved. I get them to be part of committees. I set up the proper governance. I do all of those things to drive that high-level adoption. Then as you slowly increase more complex clinical solutions, you can work to drive that adoption across those clinical solutions to maintain a high-level adoption and therefore maintain the highest possible benefits. Think of it this way. It's a lot easier to jump into warm water than it is to cold water. Taking your physicians or your clinical staff and throwing them into F is throwing them into cold water. It's a shock. Most likely, they're going to be very upset, and it's not going to work. If you start with something simple and gradually increase the complexity, not only are you more likely to be successful, but what you're also doing is you're involving the people who are actually using your systems, who can then feed back to you the best way to utilize their system to get to the best possible result. I am 100% positive they will come up with ideas that none of you individually could come up on your own. So therefore, it's really important to involve them early, get high levels of adoption, and drive it across your variety of clinical solutions. How do you apply health information technology wisely? Well, what you need to do is you need to optimize your clinical workflow, reduce your errors and risk, improve your clinical satisfaction, clinician satisfaction, and then enhance clinician usability and make it more efficient. This is how you go ahead and use Health IT wisely. And each of these is a very important step. They're interrelated, they impact each other, but these are the 5 components that actually make it work. We know today that the use of health information technology is not getting to us where we want it to go. Only 74% of physicians access a patient chart remotely, or 52% alerted them to a critical lab value, 43% to a potential medication error. Well, let me stop there for a moment. If we're going to use information technology, we're going to use computers that are really, really, really good at having a standardized database, comparing one thing to another. And yet, only it's been effective 43% of the time. It alerted to the physician to a potential medication error. That tells me that the benefits of the MR are surely not being maximized. And we need to do something around the clinical workflow to make it do a much better job. As you can see, there are other benefits of EMRs that have not been maximized, including identified needed laboratory tests. For example, some medications require you to monitor kidney function. There are antibiotics that are very toxic to kidneys, so therefore you apply them intravenously. You want to monitor kidney function. Well, this is a perfect scenario where an EMR can make sure, did you order that kidney function test? Okay? Did you order that? And it can be related to the pharmaceutical that's being administered. Yet here we see only 29% has that been effective for them. And clearly, there are other benefits here that we can look at to see where EMRs can be very effective. Let me finish up with the next couple of minutes about applied functionality, meaning how you can use the functionality with health information technology to help you? Well, there are 4 different areas. We want to make sure that the user and the role of that user, for example, a physician, a nurse, a technician, that the technology is aware of who's using the technology. Why is that important? You don't want a technician to be able to order medications, for example. You don't want non-clinical people to be able to review, say, the psychiatric part of a medical record. You want to be able to present information on the screen that's relevant to the person who is using the technology. To present to a physician a text screen does not make any sense, and to present to a technician or a nurse a physician screen does not make any sense. For example, a physician screen might include all the patients that the physician is responsible in the hospital and their location and their status. For a nurse, that might be completely irrelevant. They might be assigned to 4 patients. They need to see their own list of patients. They need to see their own data about those patients that's consistent with their workflow. A second factor is desktop roaming, meaning that a physician or any clinician who moves from place to place needs to be able to see the same desktop that they were working with from one room to another. Let me go back up a minute and give you an example. As best as I can tell, physicians are the only, and other clinicians, I include nurses and technicians in this also, clinical people, are the only professionals who never do the same thing every day. An attorney comes into his or her office, they sit at a desk, they turn on their computer, and their data is where it is. An accountant does the same thing. A marketing person, any type of professional really doesn't have their office roam with them. What they have is they have everything pretty much static. But for a physician or other clinicians, they roam all the time. Their day is never the same. The information they see is never going to be the same in the same place, in the same examining room. Therefore, instead of having excuse me, instead of having the information in one room that the doctor has to go to, why not take the whole desktop and move it with the clinician? That allows them to have their desk be with them all the time. And there's some intelligence to be built into that, which I can talk about in a little bit. The other thing is location awareness, which says, you know, if I'm at the nurse's station, I want to see all my patients in the hospital. And I want to be able to see other things, such as maybe my ambulatory care system external to the hospital, maybe my email. But when I'm in the patient's room, I don't want any of that to appear. I just want to be able to see that patient's information. I don't want email to appear. I don't want to have anything that would distract me from the care that I'm providing. If you can provide that functionality within the within the technology, then you can improve the clinical workflow. And the last piece I wanted to talk about is security. You know, we have obviously requirements around HIPAA, but we have an obligation, a moral obligation to protect personal health information. By having a very secure system, we're able to protect patient information. If we make it difficult to utilize information technology, very smart clinicians, doctors and nurses will figure out workarounds to access the technology to fit their workflow. And oftentimes, those workarounds very much sacrifice security and privacy. So if we focus on security and privacy, and as well as these other 3 areas, we can develop clinical workflows that are going to be efficient and deliver tremendously on benefits. Let's speak specifically. In order to protect personal health information, we should have 2-factor authentication: who I am and what I know. We should be able to make it easy to sign on to a variety of applications with one set of 2-factor authentication. And this way we can ensure who the person is, to make sure that any orders are authorized by that person and any data that is entered is authorized by that person. We want to make sure that it's user and role awareness. Why do we do that? We want to be able to provide the information to the person, to the clinician, at a level so that they can function at their highest level of their license, but also get the information that is appropriate for their level of license, for the assignments that they have. We can then go ahead and adjust the information that's provided based upon the credentialing. For example, if we know somebody's a cardiac surgeon, we may present information different than somebody who's just a cardiologist or just an internist. And we can then, of course, target our clinical decision support by making sure the views, the information that individual sees, is appropriate to that patient and appropriate to the role that the person who's looking at the data has. By understanding the location, we can provide patient-specific data to the clinician. I'll give you an example. If a physician is looking at patients on, say, West 2, we might be able to provide information to all of the patients on West 2. So if that physician goes to one of the rooms on West 2 and sees Sally Smith, we have some desktop roaming. They're able to see that individual patient's data. They may go to another room on West 2, and it may be okay to show Sally Smith's data with a particular alert associated with it. But if they go ahead, so that's good that we know to give them that alert that they've moved out of the room to another room to make sure you know you're working on Sally Smith now, even though you're on Mary Jones's room. But we also want to know if they go off the floor, we may go ahead and say, hey, you need to go ahead and choose your patients all over again because you've moved so far from your point of care. We want to really make sure that you're looking at the data you think you're looking at. You're not making the mistakes thinking you're seeing Mary Smith's or Sally Jones's data while you're really thinking of another type of patient. And the desktop roaming is a way, again, to take that data and move it from place to place so that the physician's desktop moves with them, the desks move with them because they move. So think about it. If you're able to apply all four of these areas, when you're putting together a clinical workflow, you can have significant impact on care, on their workflow, on your outcomes. You've got to be smart about it. Apply who the person is and where they are, and give them that data in a roaming desktop, and make sure that they have the security associated with it. That's how you create intelligent clinical workflows that deliver efficient care and high-quality care. Well, we need clinical transformation. And clinical transformation is based upon us doing good clinical workflows. We have to utilize clinical technologies. We have to impact those clinical processes in a positive way, not just mimic them. We have to focus on enhancing our quality of care and our patient safety. We have to deliver a variety of efficiencies. And the way we do this is not to do this blindly and applying it, but we have to understand what is the clinical strategy of our organization? What do we clinically want to be? What is the business model? What is our clinical business model and where we want to go as an organization, which often is tied to that clinical strategy? What processes do we need to redesign? It's not if, it's we have to. We absolutely going to have to redesign these clinical processes when you use Health IT. And then what factors, what governance are we going to put in place to facilitate the change management, to get high levels of adoption, to get input from the people who are using the system so we can be able to get to a better quality of care, a better place in using this health information technology. I just want to leave you with this quote, which is, every system is perfectly designed to get the results it gets. The professor, Paul Batalden from Dartmouth, actually coined this phrase. It's used a lot by Don Berwick. Some people actually attribute it to him. As you know, Don was also head of CMS for a period of time. But what I'm saying here, and it really, I can't hammer this home more than this, is if you are getting lousy results, mimicking the processes and replicating that process will through Health IT will just ensure that you have a greater probability of getting those lousy results. I know that sounds a little funny, but that's really what it's about. So if you have a particular processes in your hospital and it's delivering certain results for you, you cannot expect to get different results unless you go ahead and change those processes. I wish all of you luck in working to address issues of implementing Health IT to achieve better results in your hospital. And I thank you for your time today, and now I'm going to open it up to questions.
Barry, thank you very much for the informative presentation. We do have some questions that have started to come in, so I'm going to start with the kind of take them in order. The first question that came in, it says, your graph showed how the increase of complexity in processes is linked to increase in failure. Why don't we fail more often than we do in healthcare?
I like to get that question. And you know what? The reason is because of all of you. I have never been anywhere in any other, seen any other industry where people are as motivated as they are in healthcare. And they just do all the workarounds and fix it. They check it. I mean, the number of errors that occur in a hospital on a daily basis is astronomical. But what happens is we're humans and we capture, there's so much redundancy and double checking that we capture it and we prevent it from happening. So imagine for a moment what we could achieve if we had various systems, instead of working against us and increasing the probability of failure because of their complexity, we had systems that made things much more efficient and effective and helped us prevent errors. I think we'd have a huge, huge benefit.
Thank you. The next question is, what does smart workflow look like for the average clinician in a hospital?
Well, that's a good question. First off, in every organization, you're going to have a different smart workflow. The focus, again, is not on the technology. It's understanding the technology and its possibilities and then creating a workflow that will deliver a particular result. Okay? There's a lot of technology out there that can facilitate other technology. You know, technology that helps to put together a roaming desktop and is role aware is going to facilitate the use and improve the impact of an electronic medical record system. So smart workflow is understanding functionality, understanding the need to embrace additional technology to leverage the functionality, and then understanding all of those pieces and deciding on where you want to go with it. That's smart workflow. Dumb workflow is taking your existing workflow, ignoring your functionality inherent in an electronic medical record or other health IT products, and just doing what you did before. That's worse than dumb workflow. So smart workflow is leveraging all of the technology. And you might ask, how do you do that? Well, one of the things you want to do is you do something I sometimes refer to as path innovation. What you do is you go ahead, and instead of constructing your workflow immediately without any preparation, I think you need to do some background work. You bring together clinical people who might understand what a best practice is clinically. You bring together process engineering people, if you can access them, who can understand what efficiency of workflow is all about. And you bring together technology people who understand in a deep way the functionality of the technology. If you bring all these people together and then you allow them to cross-fertilize their knowledge, to educate each other at a foundation level about the capabilities of the technology, about the key issues in terms of process design, about clinical care, and then they get together and they work as a team to design a workflow that takes advantage of the functionality and uses other technology to make it work well, make it work smoothly, make it work in a way that meets the needs of the patient as well as the physician and delivers the outcomes that everybody is looking for. That's my idea of smart workflow.
Thank you, Barry. And we've got about 6 minutes left, so being respectful of people's time, we may not get through all the questions, but the next question was, you mentioned very few hospitals are in stage 7. How quickly do you think this will change, and why is stage 4 the biggest challenge?
Well, first off, let's address the issue around stage 4. As, if I go back to it, stage 4 is CPOE and clinical decision support. Remember the slide that I showed about adoption, and then I said about complexity, more complex systems, it takes a little bit longer, harder to adopt, there's more risk? Well, that's the issue here. Once you have computerized provider order entry and clinical decision support, now you're getting into the nitty-gritty of healthcare delivery. Now you're really impacting the physician. And therefore, it just takes a little bit more time to get the adoption going. Takes a little bit more time to figure out what are the alerts, reminders, clinical decision support, and other types of things that you might need. Just takes a little bit more time to even design the CPOE interface to figure out how to do a variety of ordering. So that's why you see it a bit stuck there, but I don't know if the word is stuck because I think it's going to move. So it's just going to take a little bit of time. To be smart in that area, what you got to do is you got to go ahead and do the governance right, put together the smart workflows. That's a great place to start doing that. It's going to take some time to get to stage 7 because for a variety of reasons. One is we got to get through that CPOE, CDS, and then learn what works right for your organization and get everything flowing nicely. The second thing is it just takes a while to implement a lot of these systems. And the last one is it just is going to take some time for people to give up some of the existing systems that they use today. There's a lot of change management that goes on. When is it going to happen? I don't know. It's hard to say. I think it's going to be, you're going to see some skewing. You know, small hospitals may lag larger hospitals. Academic medical centers may leapfrog ahead of community hospitals, and you'll see some regional variation. But I think as we move towards a type of prospective payment through ACOs and other types of models, only those organizations that get to that stage 7 will be able to survive because those are the only ones who will be able to implement efficient workflows and efficient care. And in order for them to survive in that prospective payment model, they're going to have to implement that efficient care.
Thank you, Barry. I think we have about 4 minutes of time for one more question here. It's, what do you think the benefits of the EMRs are not being maximized? Or, excuse me, why do you think the benefits of the EMRs are not being maximized?
Well, you know, there's a couple of reasons for that. I think first of all, overall, it's just we're in this infant stage. We're still learning how to utilize them in an effective manner. We're figuring out the workflows. A lot of the incentives are in the wrong place. I think that has a lot to do with it. You know, I like to tell a story about the use of technology back in the banking because everybody says, oh, we can do it in banking. Why can't we do it in healthcare, right? We've been working at it for all these years. Well, I don't know if many of you are familiar with this, but when I remember, I'm old enough to remember the use of the introduction of ATMs, at least in New York City where I grew up and I was going to grad school. And I remember the bank, it was Citibank, was one of the first to have ATM machines. I thought it was really cool. I obviously wanted an ATM card. I'm a technology guy, right? I got the ATM card, but the thing was, unlike today, you could only use it in one bank, and that was in Citibank at the time. And if you had another bank that you belonged to, you could only use your ATM in that bank. And what happened is all the organizations, all the banks, were competing with each other for customers. And the way they competed for each other for customers was they installed ATM machines. So people would switch from banks, one bank to another simply because, oh, there are more ATM machines. Well, somebody in the banking industry got really smart. They realized if they kept that up, there's no interoperability between banks. You know, you couldn't go to somebody else's bank, put in your ATM card, take out any money. And you couldn't look at your balance or any of that kind of stuff. There was no interoperability. And guess what? The banks didn't want interoperability. Why? Because if they became interoperable, then you could use anybody's ATM. But somebody in the banking industry got smart and realized, boy, that's a really stupid model. Why is it a stupid model? Because the banks realized they're competing on $10,000 ATM machines. And there was no way they can install enough $10,000 ATM machines around the city, around the country, to be able to secure a large enough number of bankers, of clients, of customers. So they said, what happens if we did this? What happens if we built interoperability, allowed anybody to go to any ATM machine and take out money? Hey, let's see if people actually pay us for that privilege. And sure enough, they did, as we all know. The banks were able to turn a cost center into a profit center. And that's why we all are able to access ATM today and take out all money from anywhere in the world. And the banks make money when you go ahead and do that. Well, in healthcare, we don't have a lot of interoperability simply because there's no incentive to be interoperable until today. Now there's a bit of an incentive to be interoperable. Why? Because if we're going to have some prospective payment, I want to know everything there is to know about all of my patients, whether they're my patients or they become my patients. And in order to be able to do that, it makes sense for me to put my data in a format and go ahead and share that data. And we're going to go ahead and work to share that data, and that's going to impact the way we see healthcare and what happens to it. So I think that there's a lot we need to do around clinical workflows. There's a lot we need to do in designing that, but I think we will see huge benefits from using the health IT as we increase interoperability, as we go ahead and do clinical smart workflows, and we'll start to see those benefits. We're not retail, we're not telecom. You know, we're an industry similar to playing a symphony. There's just so much efficiency. You know, you need so many players in an orchestra to play William Tell Overture. You need so many people. You can't shorten it anymore to deliver care to patients. Our efficiency is going to be built in doing things smart, preventing disease, preventing complications in people, and facilitating care amongst patients.
Great. Thank you, Dr. Chicken. And that actually gets us to our closing time. I'd like to thank all of our callers that attended the web conference today for joining, and we look forward to seeing you, as well as Dr. Chicken, who will be with us at HIMSS for 2013 in New Orleans this year. All of you have a wonderful day. We look forward to seeing you there.